Hi, this is Interpretation of Laboratory Results, Unit 2, Part 2, Coagulation. In this unit, we're going to talk about what is commonly known as coagulation, but the fancy medical term is hemostasis. Hemostasis is a series of processes that get initiated whenever there is damage to the blood vessels and blood leaks out of the blood vessels. So every time there's a rupture of a blood vessel because of trauma or because of surgery or because there's a disease process, then a series of events are going to happen, and they usually happen in a domino type of fashion. So first is blood vessels will react, and then platelet function is going to take place. And after that, we're going to have the coagulation proteins or coagulation factors come into play. Once the coagulation factors have formed a clot, a fibrin clot at the site of injury, then once the vascular endothelial cells have healed, then we're going to have the fibrinolytic system come into place and destroy the clot. But that comes after everything has healed. And then we also have natural inhibitors that are usually working alongside. Those ones can come in during any step of the coagulation of the hemostasis process. So the following slides are going to give us a little bit of information about how the different processes that are involved in hemostasis work. And on slide number 3, we have the blood vessels. The blood vessels, we have veins, we have arteries, and both meet in the capillaries. So a vein will become smaller and smaller and smaller until it becomes a capillary, and then it's going to start, growing or increasing in size on the other side so that it can become an artery. The cardiovascular system, we have to remember, is a closed system. Blood should not leave the circulatory system. It should not leave the veins. The capillaries, at the capillary level, that is where the oxygen is going to be exchanged, where nutrients are going to be moving back and forth through the permeability of the blood vessels. And one thing that is very, very important when we're talking about hemostasis or coagulation, we want to have procoagulant activity, meaning we want the body to be able to make a clot when it needs a clot at the site of injury. We don't want clots circulating in the blood because they can lodge somewhere and then they can cause ischemia or necrosis, like a heart attack if it happens in the heart, or a stroke if it happens in the brain, or a pulmonary embolism if those clots, illegal clots, that's what we call them, happen in the lungs. But they can happen anywhere in the body. So the systems are so that the clots the platelet plug and the fibrin clots from the coagulation proteins get made, get produced, get stabilized at the site of injury. So the blood vessels need to be very smooth. We don't want any plaque. We don't want anything that might accidentally activate the platelets or the coagulation proteins to become an actual clot. So there are different things within the blood vessels that are very, very important. As you may remember, the blood vessels are very rich with collagen. Collagen is a special protein that is found in all the blood vessels, in all the tissues. It's a supporting protein. And when there's damage to the blood vessels, collagen may be exposed, and collagen has the ability to activate platelets and to activate coagulation factors. So it's very, very important. And also we need the collagen so that the blood vessels can function properly, so that they can contract when needed or dilate as needed. A vitamin that is very, very important in coagulation, and I know it has a lot of other benefits, is vitamin C. If a person lacks vitamin C or has low levels of vitamin C, it's going to affect collagen production, and it's going to affect hemostasis or the coagulation process. Remember, we have collagen pretty much everywhere, and it has the ability to activate the platelets and coagulation factors, especially coagulation factor 12. There's this other protein called tissue factor that is found in the tissues in blood vessels. Every time the endothelial cells of the veins or the arteries of the blood vessels get exposed, then this tissue factor will be released into circulation. And what it does, this tissue factor, it activates another coagulation protein, factor 7, coagulation factor 7, that once it gets activated is going to end up making a fibrin clot. And we'll see how that happens in some slides that are coming up. One of the very first steps that happens whenever there is damage to the blood vessels is vasoconstriction. And the vasoconstriction happens so that there is an instinctive reaction of the blood vessels to shrink so that no blood, or minimize the loss of blood, because blood we lost until we have a clot, but the vasoconstriction will at least prevent a heavy flow of that blood. So this is just information, basic information about the substances that are in the blood vessels that will help us in case there is leakage of blood into the tissues. Then we have the platelets. The platelets, we mentioned them in the hematology unit. The platelets are made in the bone marrow. We have quite a few platelets per microliter of blood. We have about 150 to 450,000 platelets per microliter of blood. So we have a lot. And we need to remember that we have another third of whatever is in circulation, another third of that total number is stored in the spleen. So we have about another 150,000 platelets stored in the spleen to be released as needed on demand in case of trauma or acute bleeding. If the patient is suffering hemorrhage, then those platelets will be released so that they can go to the site of injury. Remember, platelet activation has to happen at the site of injury. We don't want them to form a platelet plug in circulation. The line of platelets is about 9 days or plus or minus 2, so 7 to 11 days, give or take. And they come from the bone marrow. They are made by the bone marrow. And the precursor cell, or the parent cell of the platelets found in the bone marrow, is the megakaryocyte. So the megakaryocyte comes directly from the stem cell. And if you go back to the hematology, one of the first hematology slides where we have the schematic of how the stem cell can become different cells, you would see that you start with a pluripotential stem cell, and then through different cytokines, eventually we're going to end up with a megakaryocyte that should only be found in the bone marrow. And out of the cytoplasm of the megakaryocyte, then as the cytoplasm fragments, those fragments of cytoplasm are what we have the platelets. Those become platelets. And you have a little picture on the right-hand side on the column on the right side that you have the megakaryocyte cell, huge cell, is the biggest cell in the marrow. And it has a lot of cytoplasm, and that cytoplasm will become individual platelets. The platelets do not have nucleus. They do not have a nucleus, but they have a lot of granules. And the granules that are within each platelet are the ones that are responsible for platelet function. Another thing to remember is that there is a hormone that is produced in the kidneys and a little bit in the liver and a little bit in the spleen, but mainly in the kidneys. There's a hormone that will tell the bone marrow to make more platelets when needed. So this hormone produced mainly in the kidneys is called thrombopoietin. So remember, thrombopoietin is the hormone that tells or stimulates the bone marrow to make more platelets. And platelets are very small. The shape they have is like lentil shape. If you have ever seen the lentils, they look like that. And they have the ability to form pseudopods, to bend out of shape so that they can cover more space whenever they need to cover a hole to prevent the blood from leaking out. Um, Going back to the granules, remember there's granules. There's no nucleus in the platelets, but there's granules in the granules. They have specialized functions. They have and they are divided depending on their function. They are either alpha granules or delta or dense granules, and they have different substances that are going to make it possible for platelets to actually work well. In slide number 5, we actually go into what the steps that happen when platelets get activated. So whenever there is a leak in any blood vessel, whenever there's a rupture of the endothelial cells that make up the blood vessel and blood begins to leak out of the blood vessel, then the different substances, tissue factor, the collagen, the van Willebrand factor, there are different factors that are going to be released and exposed, and some of those substances are going to activate the platelets that are going through, that are passing by. They are going to become activated so that they can form a platelet plug. So the net function, the goal of platelet activation is the formation of a platelet plug. And it happens in 3 stages, and they go in step-like fashion. First is adhesion, and meaning the platelet will be activated as they are going by the rupture endothelial cells. They will be activated, and once they get activated, they will adhere to non-platelet surfaces, meaning they are going to go to the site of injury and they are going to get activated by the collagen that is exposed, and they are going to reach out, they are going to get stuck to the collagen around the area where the damage is. Once the platelets have adhered, then they are going to try to aggregate. And there is 2 types of aggregations, primary and secondary aggregation. Primary aggregation is once the platelets get the site of it to the exposed collagen, they are to change shape, to form pseudopods. They're going to reach out to each other so that they can form like a net, and they are going to try to make contact with each other. So primary aggregation is the sticking of platelets to other platelets. So adhesion happens first, is the first step in platelet function, and is when the platelets get stuck to the collagen, to non-platelet surfaces. Primary aggregation is when the platelets are making contact, they are sticking to other platelets. Once they have done that, these first two steps, the adhesion and primary aggregation, they are reversible steps, meaning that if a platelet happens to change its mind or it doesn't really change its mind, right? They don't have a choice. But let's say that because the blood is still flowing through, and they get dislodged from the site of injury, they will be okay. They will go back into the lentil form, and they will continue in circulation because the first 2 steps are reversible. So they still have the integrity, they still have their granules, they can continue to become platelets. But if they stay at the site of injury, once they adhere and then they primarily aggregated with each other, then the third and final step is what we call secondary aggregation or secretion. I like to call it secretion because it differentiated from primary aggregation. But what happens during secretion is what the word says. The platelets will secrete all their granules at the site of injury. They are going to release the alpha and the delta granules that contain serotonin, that contain ADP energy so that they can continue to do their job. It will contain fibrinogen, platelet factors, all these substances that are going to make it possible for them to form a platelet plug at the site of injury to try to prevent the blood from leaving the blood vessels. So if the platelet plug is not enough to stop the bleed, to stop the leakage of blood at the site of injury, then the coagulation factors are going to be activated at the site of injury, and they are going to form what we refer now to as a fibrin clot. So remember, platelet function, the net effect of platelet activation is the formation of a platelet plug. And that usually happens, the easiest way to remember that, there are a lot of substances that can activate platelets, but collagen is one of the most obvious one, because we know that collagen is exposed whenever there's injury to the blood vessels. There is a video there that you click on in your slide number 5 at the bottom, that you can see this the animation, and it's a pretty good visual. If you want to take a few minutes to watch the video, it makes a lot of sense. Slide number 6 then tells us to very specific things that we need to remember about. Okay, so what do we need to know about monitoring primary hemostasis? Primary hemostasis is the function of the blood vessels and the platelets. So what is the role of the laboratory in primary hemostasis, in blood vessels or in platelet function? Well, we need to, every time we need to know whether we have good primary hemostasis function is by checking blood vessel function. And there's not a lot of tests that we can do about or to assess or monitor the blood vessel or the vascular integrity. But we can definitely check platelets. We can check the number of platelets to see whether there's thrombocytopenia. Remember that penia denotes low levels of, so thrombocytopenia, that is a decrease of platelets. And if we don't have enough platelets, then we are going to have more or prolonged bleeding, especially mucous membrane bleeding. What if we have enough platelets? If we have a good number of platelets per microliter, we do the CBC and the platelet count is normal. But what if they are defective? What if they don't know how to do their job? Or what if the patient is taking some medicine, so like aspirin or like Plavix or any number of medicines that can interfere with platelet function? So we want to be able to see the numbers of platelets and also the function of platelets. And there are different things that we can do to check platelet function. And one of them, and it's an old test and is not commonly ordered anymore, but it's still around, and is the bleeding time. So the bleeding time test is used to monitor platelet function. And it's done by the bedside, and is usually done by the phlebotomist. And now this bleeding time is being replaced by some other more sophisticated point of care test that can be done, by anybody at bedside on the patient, just to give the doctor an idea whether the patient's platelets are working properly or not. In slide number 7, we start with the actual coagulation factors. Coagulation factors or coagulation proteins that are made in the liver. The coagulation cascade is what we also refer to as secondary hemostasis. So secondary hemostasis is the activation of coagulation factors or coagulation proteins. These are specialized proteins that are made exclusively in the liver. All of us have to have a certain amount of those coagulation factors in circulation at a given time. And they are in circulation, just going around and around in an inactive form. They are not active until there is some damage to the blood vessels that requires the formation of a fibrin clot. So all of us have inactive coagulation factors, and we need to have a minimum of 30% activity for each one of them for us to be able to maintain normal hemostasis. But the laboratory will have to do the testing to see how much activity. We usually go by activity. There's a couple of factors that we measure in milligrams per deciliter, but mostly we go by factor activity. So just so that you know, in the other slides, we're going to see how they work. But we have about 1 to 13, and they are the coagulation factors have been assigned Roman numerals from 1 to 13, but through the years they have found out that not all of them are factors. So some of them have been deleted out of the coagulation cascade. But for now, we have from factor 1 to factor 13, with some exceptions in the middle. And something to remember, coagulation factors are not going to work unless there is ionized calcium to help them go from it inactive to active form. Okay? So there are something else that we need to remember is that all the coagulation factors are in the liver, but some of them require a special vitamin for them to be fully functional. And those factors are factor 2, 7, 9, and 10, that we call them the vitamin K dependent factors, meaning the liver makes them, but then vitamin K has to be present to actually finish the final, like to polish them off. Without them, then they are going to be useless. And that is important because there is a very common anticoagulant that is given to outpatients that interferes with factors that are vitamin K dependent, and that is coumarin. Coumadin or coumarin or warfarin, same medicine. The way it works is that it prevents coagulation by inhibiting the vitamin K dependent factors. So it inhibits that vitamin K from actually finishing off and making those factors viable or ready to work. So remember, there are some coagulation factors 2, 7, 9, and 10 that are vitamin K dependent, and that they are inhibited by the anticoagulant coumarin or warfarin. Where do we find vitamin K? We ingest it in leafy greens, walnuts, some fish, but the main source is the normal flora of our stomach, or our intestine, not the stomach, but the intestine of our gut. We need to be aware that the specimen for coagulation studies, PT, INR, PTT, or the D-dimer, those are usually the 3 most commonly ordered tests for hemostasis or coagulation. They require the sodium citrate or the blue top tube, and you need to have a full tube. There is actually, the manufacturers have all made it so that there is a line, so it has to be full to that line, because it contains a lot of anticoagulant. When you have a chance, look at those blue tops and see how much liquid, how much anticoagulant is in there, and it will dilute the specimen. So there has to be a full container. It doesn't have to be all the way to the top. With a vacuum, it will stop by itself. So you have to allow it to fill up to itself. It has to mix very well without shaking, just mix in by inversion. And it has to be processed very, very fast. We want it to be processed as soon as possible, but definitely within 4 hours, because there will be some factors. There's a couple of factors that are very, very unstable. I call them the wimpy factors. It's factor 5 and factor 8, and they die off. The activity is lost within hours. So if it is not going to be tested right away, then we want to spin it down and separate it and put it in the refrigerator. They can be 4 hours is tops, and for PTT, but for T, we can wait until to about 8 hours. After that, the specimens are really no good. So specimen integrity, very important. Things to remember about pre-analytical factors that can affect test results. also can lead to diagnostic errors. This would be it. Collecting a good specimen, a blue top specimen for the PT, INR, PTT. Slide number 8 shows us each individual factor, and it gives us our name, and it tells us a little bit about it. So the number 1 factor is fibrinogen, and that is one of the ones that we have the most of. We have a lot of fibrinogen. It's so much that we don't actually measure it in activity. We measure it in milligrams per deciliter, and we have about 200 to 400 milligrams per deciliter of fibrinogen inactive, right? It's not active until another activated factor comes and activates it, and that would be number 2. So we have factor number 2 is called prothrombin, and in the presence of calcium, remember calcium, ionized calcium will be sprinkled here and there so that things can happen. And then activated factor 2 will activate factor 1, fibrinogen, to become fibrin. So you can go through this slide, you'll see which ones are not a factor, and a note, important note, factor 8 and factor 9. Because deficiency of factor 8 or deficiency of factor 9 are what lead to hemophilias. And hemophilia A is deficiency of factor 8, and deficiency of factor 9 or Christmas factor, it will lead to hemophilia B. You need to be aware of those two because those are the two hemophilias that are most commonly seen, and you just need to be aware of those two hemophilias. There are some other diseases that are certainly more common than this ones, but hemophilia A and hemophilia B is something that if you have a little bit of medical knowledge, you should know a little bit about these deficiencies. The way I like to look at how these coagulation factors work is in cascade fashion. So we start from the top. So we start with 12 or 7 on the other side, and we end up with 1. Because the activation of factor 1 or fibrinogen, when fibrinogen gets activated, it will be fibrin. And fibrin strands are going to interlock together, and they are going to form a clot. The clot that will seal the hole in the blood vessel to prevent blood. And as you can see on slide number 9, we have like a Y formation, right? We have on the left, we have factor 12. Remember, these are Roman numerals, and if you do not remember your Roman numerals, I would advise you to write them down on a piece of paper and to have them handy, especially during quiz or exam time, so that you know which ones we're talking about. So factor 12 is the first factor to be activated in the intrinsic pathway. So the coagulation factors, they can be divided depending on how they are activated. They can be divided in intrinsic pathway, extrinsic pathway, or the common pathway. Okay, the common pathway is not really marked here, but I will tell you where it is. You have the notation right there at the bottom of the slide, but we have the intrinsic factors starting with the activation of factor 12, and factor 12 activated by collagen. See, collagen activated platelets, and collagen can also activate factor 12. Factor 12 can be activated by some other stuff. There's many different things that can activate factor 12, but to simplify the process, just you need to remember that. So the intrinsic pathway, the activation of factor 12 by collagen will lead to, in domino fashion, okay, once 12 gets activated by collagen, then activated 12 will activate 11, factor 11. Once factor 11 has been activated, then is factor 11, activated 11 is going to activate 9, factor 9. Factor 9 will need needs a sidekick. It needs help, and that is factor 8. So factor 9 and factor 8, when they are activated together, will activate factor 10. Factor 10 is in the middle. Factor 10 is the beginning of the common pathway. So factor 10 will become activated by 9 and 8, and then it will activate 5. Activated 5 will activate 2. Activated factor 2 will activate factor 1, and factor 1 will become fibrin. So that is the whole domino. Is like playing tag. Once you have tag, once you're tagged, then you're going to go in, tag somebody else. This should be in order. 11 or 5 or 2 should not be activated out of sequence, because if it does, the natural inhibitors, these other very specialized proteins that were mentioned in the second slide, then those natural inhibitors are going to come in and neutralize that illegal activation of that protein. So intrinsic pathway will be 12, 11, 9 plus 8, together will activate 10. 10 will activate 5, 5 will activate 2, 2 will activate 1, 1 becomes fibrin when it's inactive. So that's the intrinsic pathway up until you get to 10. Then it's common. We call the common pathway when we start with 10, because if you look to the extrinsic pathway, we have tissue factor. Tissue factor will activate factor 7. Activated factor 7 will activate a common pathway that is 10. Then 10 will activate 5. 5 will activate 2. 2 will activate 1, and 1 will become fibrin. That's the extrinsic pathway. So how do we know if these pathways are working okay, or the factors that are involved in these different pathways are working okay? Well, we can run the PTT. And whenever we're running the PTT, then we are monitoring, we're assessing the function of the factors involved in the intrinsic pathway, that is 12, 11, 9 plus 8, 10, 5, 2, and 1. If we're running the PT, then we're assessing or monitoring the factors involved in the extrinsic pathway, and we have factor 7, and then activated 7 will activate 10, 5, 2, and 1. Something to remember, guys, this is all happening simultaneously. This all happens, it is in step-like fashion, but is all happening at once. Why? Because if you're bleeding, if there's damage to the blood vessels and blood is getting out, if you're bleeding out, then you need help. Something has to stop the bleed. And if we can see the bleed, like in the outside, right, we're going to put stitches or staples or a band-aid, but there's bleeds that happen in vivo. We cannot see. Have you ever hit yourself, by walking on the edge of something, and then it's like, oh, it hurts. Like you hit yourself on your thigh, and you say, oh, yeah, it hurt really bad. But you don't see anything. There's no bleed. There's nothing there. You just know that it was really, really painful. But there might be bleeding inside, and this process is already underway to prevent the blood from leaking out of the blood vessels. And sometimes you can even see it, because if you end up with a bruise, that means that there was blood vessel damage, that blood leaked out of the circulatory system, and it had to be a clot to stop the bleed and to prevent any further blood from escaping the blood vessels, and for the tissue to heal. So coagulation cascade, all of us have all these factors. At any given time, all of us have to have a certain amount of these factors ready to work. They should only work when there is a cause for them to be activated so that they can become a fibrin clot. And you need to know, test question will involve information about the intrinsic pathway, and you have information on the left, and then the extrinsic pathway, and then the common pathway. Something about information about the PT INR, and this is very common. This is a combo, and other doctors don't even want, are not really interested in the PT. They only want the INR, but they cannot have the INR without the PT. The INR is a mathematical calculation based on the patient's PT result. So the instrument, the laboratory instrument, will provide it to us once we put in the patient's PT result. So once we have the PT's result, we put it into a formula, and then we'll get the INR. And that is very important if the patient is taking coumarin, and the doctor is trying to monitor the anticoagulant dose that is needed for that patient. On slide number 10, we have explanation of what I just said for the 3 different pathways. So the coagulation cascade involves 3 different pathways. You need to be aware which factors are involved in each pathway, which factors are found in the intrinsic pathway, which factors are found in the extrinsic pathway, and which ones are part of the common pathway. So for the extrinsic pathway is very easy. There's only one. The intrinsic pathway is 12, 11, 9, and 8. The common pathway is 10, 5, 2, and 1. And you can see that in the picture of the coagulation cascade. But that information is also present here in slide number 10. And then slide number 11 tells us what the importance of the PT-INR and the PTT test are for, what it is that we are measuring or assessing when the doctor or a clinician orders the PT-INR and the PTT. Then coagulation disorders. This can be very complex, but we only have here very basic information. Remember that I told you about the hemophilias? We can have acquired disorders or inherited disorders. And unfortunately, we can have inherited disorders and end up with deficiencies or malfunctions of every single one of those coagulation factors. There can be inherited mutations that can lead to a malfunction of factor 5, or a dysfunction of factor 10, or a problem with factor 1. But it's just that goes back to genetics. The 2 most common inherited disorders are the hemophilias, and by far the most common is hemophilia A, or deficiency of factor 8, and then followed up by hemophilia B, or deficiency or problems with factor 9. Hemophilia B is also known as Christmas disease. Christmas because the doctor that first made the discovery, his last name was Christmas. So it's hemophilia B, deficiency of factor 9, hemophilia A, deficiency of factor 8. Both of them have the same signs and symptoms, so a patient would show similar problems. We'll go to the doctor with similar signs and symptoms. Only through laboratory tests will we be able to say it's a deficiency of 8 or it's a deficiency of 9, factor 9. The acquired disorders are by far the most common. Why? Because all the factors are made in the liver. So every time a patient has liver problems, we might end up with coagulation problems. If the liver is not functioning correctly because of any toxicity, or because of viral infections, or because hepatic coma, or for whatever reason, if the liver is not working properly, it will not be able to make the right amount or functional factors that we need, because remember, they are made in the liver. If we happen to have a deficiency of vitamin K, if for whatever reason we end up being deficient, then that is also going to lead to problems with coagulation, and they can lead to bleeding. Okay, and this gives you a little bit of that information. And then we have the fibrinolytic system. So we had injury to the blood vessel. There was a ruptured blood vessel. The blood vessel, we started losing blood through that injury. Then the platelets were activated, and we ended up forming a platelet plug. And then on top of that platelet plug, the coagulation factors were activated, and then we formed a fibrin clot. And now we have a whole consolidated clot at the site of injury, preventing blood from leaving that blood vessel. That clot will remain in place until the blood vessel, until the endothelial cells have grown back, until there's complete healing of that blood vessel. Then the clot is going to be broken down into small pieces. And this happens a little bit at a time. This is a very, very slow process, because as the wound is healing, as the blood vessels are repairing themselves, then little pieces of the fibrin clot are going to be dissolved. They are going to degrade the clot one step at a time. And the fibrinolytic system involves the conversion of just one factor. And this is plasminogen, is the factor that the name of the factor that is responsible for breaking the clot, but plasminogen is inactive. It will only degrade the clot when it has been activated to its enzyme form, and that is plasmin. So plasminogen will be inactive, will be part of the clot, and different substances can activate it. The number one substance is tissue plasminogen activator. I love it when it makes sense, right? So we have this substance that is going to activate plasminogen so that it can become plasmin. Once it's plasmin, then it's going to start degrading or breaking down the fibrin clot, and we can measure that. We can actually see how much activity, fibrinolytic activity, we have through fibrin degradation products test or fibrin split products. It's the same test, slightly different names. But if we really want to get to the most detailed amount of fibrinolytic function, then we would do D-dimer test. The D-dimer is very good indicator and can help the doctors rule out nasty conditions like deep vein thrombosis or pulmonary embolisms, or to assess disseminated intravascular coagulation. So the D-dimer, very, very good, very detailed test that gives us a lot of information. But again, we also have that FDP test that can help us assess the fibrinolytic system. And the last slide is just a little bit of information about the natural anticoagulants or the natural inhibitors. Again, these proteins are always looking around for any factor that gets activated out of sequence. If a factor is activated out of that cascade, out of that sequence that we saw in previous slides, then these natural anticoagulants, and we all have them. And if we don't have them, then we're going to be prone to illegal clots or thrombi. We can have a lot of problems with thrombosis. So we all have natural anticoagulants or natural inhibitors. They do not block the hemolytic, not the hemolytic, the hemostatic process. They don't block the activated factors when they are being activated in sequence. They will only work. They will only be activated when there are factors that have been activated out of the cascade order. So just remember, and we have some examples here. We have the antithrombin 3, very, very potent anticoagulant, natural anticoagulant, works together with natural heparin that we have in our tissues. And then we have the protein C and its cofactor protein A that neutralizes factor 5 and 8. So each one of them have specific, they go after illegally activated specific factors, but they are always working so that we don't end up with clots in the wrong place or just circulating in our body, because remember, we do not want clots in circulation. We want platelet plugs and fibrin clots at the site of injury. Okay, guys, I hope this helps. If you have any questions, don't hesitate to reach me.